Welcome back. This explainer is based on the Comprehensive Review, BPV, Recognizing and Treating All Canal Variants, published by Australian Dizziness Clinics. Today, we are officially wrapping up our four-part series. We're going to bridge the gap between identifying those tricky canal variants and managing exactly what happens after the maneuver. Clearing the debris doesn't always fix everything right away. So we'll look at residual dizziness, recurrence rates, and those critical referral triggers you need to keep top of mind.
But first, just to set the stage here, BPPV accounts for up to 50%, literally half, of all vertigo cases in older adults. It's incredibly prevalent in the clinic. Yet so many of these patients end up just sitting on vestibular suppressive medications instead of getting the targeted physical therapy they actually need from us. And that's our real shame, because here is the standout metric. 80 to 90% of these cases achieve complete symptom resolution with a single well-executed repositioning maneuver. That is a staggering success rate, right? It's exactly why mastering these clinical pathways and knowing what to do when that one maneuver doesn't quite cut it is absolutely crucial. Here is our clinical roadmap for today. We'll touch on the mechanics of BPPV, walk through the diagnostic pathway, cover the posterior, horizontal, and anterior variants, and then finish up with aftercare and referral strategies. Section 1, Mechanics of BPV. Let's start by understanding otoconia. To successfully treat any variant, we have to recognize the critical difference between the two main presentations. With canalithiasis, you've got free-floating particles. When the head moves, they drag the endolymph, bend the stereocilia, and you get that transient, fatiguing nystagmus. But with cupulolithiasis, those particles are actually adhered directly to the cupula itself. This weighs it down and creates a persistent deflection, meaning a much more sustained nystagmus. Section 2. The diagnostic pathway. Time to map the canals. When we look at this diagnostic decision diamond, the distribution really jumps out at you. You've got an overwhelming 85% of cases involving the posterior canal. Then, the horizontal canal makes up about 10%, and way down at the bottom, the anterior canal sits at just 1 to 2%. This flowchart is your best friend in the clinic. It reminds us to systematically select tests based on likelihood and to always recheck our diagnostic tests after every single maneuver. Section 3, Posterior Canal Variants. This is your most common presentation. Okay, so for diagnosing this classic variant, it all comes down to executing the gold standard Dix-Hallpike maneuver flawlessly. You know the drill. Seated to supine, head extended about 20 degrees below horizontal, and rotated 45 degrees toward the affected ear. But what are we really hunting for here? It's that characteristic up-beating torsional nystagmus. It beats upward and rotates right toward that affected ear. I absolutely love this clinical pearl from the literature because it shows how one tiny timing detail can completely shift your differential. The cardinal feature here is the delayed onset. You need to look for that 3 to 10 second latency period before the nystagmus even kicks in. That's the time it takes for the particles to overcome endolymphatic drag. If your patient feels dizzy the absolute second they hit the table, but their eyes are rock steady, you might actually be looking at anxiety or a cervical issue, not true BPPV. Once we've locked in that diagnosis, we go straight to the gold standard Epley maneuver. By moving the patient systematically through these timed positions, we're literally using gravity to walk those particles right through the posterior canal, out the common crus, and back into the utricle. And hey, a quick note on post-maneuver care since we're talking about treatment. That old advice about strict 48-hour upright posture, it's no longer evidence-based. A gentle 24-hour recommendation to just avoid provoking positions is completely reasonable and much easier on your patient. Section 4, Horizontal Canal Variants, covering both geotropic and apogeotropic. Moving on to that 10% of cases, the supine roll test is your go-to. You lay the patient flat, rapidly rotate their head side to side, and watch for horizontal nystagmus. If it beats toward the ground, the undermost ear, we call that geotropic, which usually points to free-floating canalithiasis. But if it beats up toward the ceiling away from the ground, that's apogeotropic. And this is where horizontal variants can get a little tricky. That direction-changing apogeotropic presentation strongly suggests cupulolithiasis, meaning the crystals are stubbornly stuck to the cupula. Because of this, it often responds a lot less completely to standard treatments. You're going to need a highly individualized approach here, sometimes requiring multiple sessions just to convert it into a treatable geotropic form first. Now, for the more common geotropic horizontal BPPV, the BPB roll maneuver is highly effective. You literally roll the patient in 90-degree steps away from the affected ear, pausing at each step to let those particles settle. It's a simple, systematic roll, but it boasts an impressive 85 to 95% success rate on the very first try.
Section 5, Anterior Canal Variants. Rare, but crucial.
Making up just 1 to 2% of cases, anterior canal BPPV is often completely missed, or worse, misdiagnosed as a posterior variant. When you perform your testing, like a deep head-hanging maneuver, you are looking for an atypical downbeating nystagmus. It beats downward right toward the chin. If you accidentally mistake the slight torsional rotation of the eye for an upbeating movement, you'll misdiagnose it, and your Epley maneuver is basically guaranteed to fail. The major takeaway here, if you see downbeating nystagmus, hit pause. Downbeating nystagmus can actually be a massive red flag for central neurological pathology. The Australian Dizziness Clinic's review strongly advises confirming this diagnosis, potentially using video nystagmography, or VNG, before you just assume it's an anterior canal issue and attempt a reverse Epley. Safety first, always.
Section 6, Algorithms and Wrap-Up. Let's look at your clinical toolkit. This first flowchart brilliantly distills the diagnostic process. It splits initially between suspected posterior or horizontal issues and cleanly defines the rules for each. Upbeat torsional, posterior. Geotropic or apogeotropic, horizontal. But crucially, it reminds us to watch for central mimics. You need to refer out immediately if you see direction-changing vertical nystagmus. You should also trigger a referral if symptoms are stubbornly persistent past 3 sessions, or if the patient is under 40 with no history of head trauma, or if they have sudden hearing loss. Once you've got the diagnosis, this algorithm ensures you pair the exact right repositioning maneuver to the identified canal. Posterior gets the Epley. Horizontal geotropic gets the BBQ roll. Anterior gets the Iacovino. But remember our theme today. Maneuvers clear debris, but they don't fix everything. Even after successful repositioning, 30 to 40% of patients will have residual nonspecific dizziness for days or even weeks. Treat this residual deconditioning with brief vestibular rehab, focusing on head-eye coordination and graded motion exposure. Don't just keep repeating the repositioning maneuver.
And before we officially close out this series, we have to talk about recurrence. It happens in about 15% of patients at 1 year and jumps to 50% at 5 years. Risk factors include things like osteoporosis or head trauma, but here's a huge tip. Check for vitamin D deficiency. Supplementation can reduce recurrence rates by 30 to 40%. So, to wrap up our 4-part explainer series, canal-matched maneuvers deliver high cure rates, but you must recheck, address those residual symptoms with brief VRT, and refer out when things look atypical. I highly recommend visiting AustralianDizzinessClinics.com for the full literature review and clinical cheat sheets. Make sure to subscribe and rate. So based on everything we've mapped out today, from identifying those downbeating red flags to properly managing residual dizziness, what subtle nystagmus clue will you confidently catch in your next assessment that someone else might have completely missed? Think about it, and let that guide your next successful treatment.